Okay, so I'm assuming everyone can hear. So if anyone is struggling, then can you type a response, and Emily and Courtney will sort that out for you. But just want to say welcome to everyone, and it's great that you're able to join us. So this is one of our webinars in the series of webinars that connects people who are doing work in relation to the mortality of people with intellectual and developmental disabilities. The series of webinars was funded for 3 years by the ESRC in England. That 3 years is now up, actually. So this is the last kind of official webinar under the jurisdiction of the ESRC funding. But what we have been able to do is to transfer some of the funding to Emily's team so that we're able to continue the webinars and their funding slightly. So hopefully that suits everybody, and we can catch up a little bit more about that at the end. So for the webinar today, just want to go through a quick overview of what we're going to be covering. Lisa O'Leary has recently had a systematic review published about mortality of people with intellectual disabilities. So she's going to talk us through the findings of that systematic review. And then there's a chance for everyone on the line to just update us on some of the work that you're doing. Jenny's sent us some slides, so we've got those ready. But if anyone else wants to just update us quickly about your current work, then that would be great and very helpful. And then Emily and I will just update you from a meeting we had at the IASID Health meeting in June, which is quite a long time ago, really, and just update you with some of the work that we planned as a result of that meeting, and we kind of like some agreement and support from the group to take that forward. And then next steps for the series of webinars. So it's a bit of a packed agenda, but we hope that you'll find it interesting. So thanks once again, and over to you, Lisa.
So thanks everyone for joining. So I'm just going to present some of my findings from my systematic review, which I worked on alongside some colleagues at the Scottish Learning Disabilities Observatory at the University of Glasgow. And these findings look at early death and cause of death of people with intellectual disabilities. So just in terms of the rationale for the study, so it's commonly known that people with intellectual disabilities have poorer health outcomes than the general population, and it's commonly known that mortality is a good indicator of poor health outcomes and also health inequalities. So what we wanted to look at all the evidence that is currently available in relation to cause of death and early deaths and life expectancy of people with intellectual disabilities. So we identified that a systematic review would be the most robust method in order to assess this evidence. So we aimed to identify evidence for the life expectancy and age of death of people with intellectual disabilities, and also identify determinants of early mortality for people with intellectual disabilities, and identify the main cause of death for this population as well. So we constructed a comprehensive systematic review combining terms related to death and intellectual disability, and we searched 5 separate databases which are listed on the slide there. So we had strict inclusion and exclusion criteria when we were filtering out the findings for our systematic review. So we included all years, and it had to be primary research, needed to be peer reviewed. The studies needed to have at least 50% of participants had to have an intellectual disability, if not reported separately, and participants could be all ages. So the outcomes we were interested in looking at included deaths, crude mortality rates, life expectancy from birth or later, standardised mortality ratio, and age of death. So in terms of, we excluded full papers not available in English, and we excluded studies where the proportion of the participants with intellectual disabilities were unclear, or less than 50% of the sample were not reported separately. And also we excluded studies where they might not be representative of people with intellectual disabilities in general, and also subgroups where, such as people with Down syndrome who may have a unique mortality profile. So I used EndNote software to extract all the findings, and the title and abstracts were checked for eligibility against the inclusion and exclusion criteria. A selection were checked with a second reviewer as a form of, in order to reduce risk of bias. And we also undertook narrative analysis of the findings. So sorry, I see there's still an echo. I'm not sure how to rectify that. I see there's still an echo, so sure if anyone else. Okay, I'll try and see how it goes anyway. So the information was tabulated, so information like such as study design and the profile of the participants was tabulated, and we used CAS scores to look at the quality appraisal of the studies, so to critique the studies. So here's a Prisma flow diagram which illustrate all the stages that we went through in terms of screening the titles, the abstracts, and also the full text. And we identified 27 studies that were eligible for the systematic review. So I'm just going to briefly mention the findings. So in terms of the evidence for early death, we found that, so first of all, there was different methods used across the studies to report age of death, and these included median or mean. But overall, in terms of looking at the studies, we identified that average age of death was about 10 to 20 years younger than the general population. And in terms of mortality rates, though the studies that reported standardized mortality ratios, so this is basically a comparison of the age and gender matched samples, these range from about 2 to 5 times the general population. And an interesting finding that was reported in many of the studies was that standardized mortality ratios were higher with females with intellectual disabilities compared to males. So this may indicate perhaps, we're not sure the reason for this, but this may indicate perhaps level of health inequality, which perhaps needs to be investigated further, and perhaps more research in this area would be good. And also we identified that certain groups with comorbidities, such as in a lot of the studies, problems such as mobility problems, eating problems, or vision or hearing impairments, and also severe intellectual disability. These groups, this had a poor effect on age of death and also mortality rates. Also, another interesting finding was that standardized mortality ratios were higher for young adults and also children, and this may indicate perhaps a healthy survival effect, wherein the individuals without comorbidities or with milder intellectual disability are more likely to live to an older age, and therefore will have a life expectancy and mortality rate in line with the general population. So in terms of looking at the evidence for underlying causes of death in people with intellectual disabilities, we identified that respiratory disease appeared to be one of the main underlying causes of death that was reported in a lot of the studies, and we identified that respiratory disease appeared to be a lot more common as an underlying cause of death than for the general population, and pneumonia appeared to be also a main underlying cause of death. Circulatory disease was also a main cause of death in people with intellectual disabilities, and there appeared to be some difference in the type of underlying causes, or the different types of circulatory disease that were more prevalent in people with intellectual disabilities, in that there was a greater prevalence of congenital defects as an underlying cause of death reported, whereas ischemic disease was less common as an underlying cause of death compared to the general population. And this may perhaps, there was some reports of this potentially maybe because of the lower rates of smoking in people with intellectual disabilities. So cancer was also reported in a lot of the studies as being a less common cause of death than in the general population. And where cancer deaths were reported similar to the general population, it was reported that they increased with age. In terms of, there was a few studies that reported the types of cancer deaths, and those that did report the types of cancer deaths, digestive cancer there was a different profile of deaths. So digestive cancer was reported to be more common as a type of cancer death in people with intellectual disabilities compared to, say, breast cancer and other cancers which may be more common in the general population. And it is proposed that this may be because that because of the diets of people with intellectual disabilities. And I see that there's a new interesting systematic review that's been published, which looks at it looks at constipation in people with intellectual disabilities, just been published in JARID recently, and that this is often not dealt with effectively. So this may be potentially a factor that influences this profile of digestive cancers. So, and also, and this leads nicely to the next point, which was found that in a few recent prominent studies in the UK, it was identified that people with intellectual disabilities are more likely to die from causes that are amenable to healthcare intervention. So, so this indicates that there needs to be more better management of healthcare conditions and reasonable adjustments for people with intellectual disabilities to avoid early death in the future. So there was, in terms of looking at the evidence in this systematic review, there was some criticisms of the studies in terms of the methodology and the lack of generalizability. So this is an important finding of the systematic review, which should be used to inform future studies. Not all the studies made comparisons with the general population, so therefore it was difficult to determine whether the level of health inequalities, to determine the level of health inequalities experienced. And also those that did make comparisons with the general population, not all of these had age and gender matched samples, so therefore therefore more rigorous age and gender matched samples need to be undertaken. Also, there was a reliance on administration samples as well. So, and therefore there could be some cases of people with intellectual disabilities being missed out, potentially those who access services. Also, a lot of the studies relied on death certificates, which can potentially have coding errors in terms of not being coded consistently across regions. And also, a lot of the studies didn't provide limited information on contributory factors to cause of death, and this is a really important criticism, as we need to build up a picture of the chain of events that lead to avoidable causes of death. And also, all of the studies were undertaken in high-income countries, so it would be good to undertake for future research looking at mortality profiles in middle and lower income countries where the healthcare systems may be different. So in conclusion, it is difficult to draw definitive conclusions about the evidence for early deaths and specific causes of death, of people with intellectual disabilities and how this compares to the general population. But this systematic review has provided a lot of evidence in terms of pointing to the need for future research in terms of more robust standardised data in relation to identification and characteristics of people with intellectual disabilities and standardised age bandings and definition of intellectual disabilities across countries. And I think a really important finding as well out of this is the gender differences in terms of the standardised mortality ratios. So it would be good to perhaps follow this up in terms of perhaps comparing male and females' experiences of accessing healthcare services. So there's a lot of future research that needs to be undertaken, and I would encourage you to have a look at, to have a read of the systematic review. It's in this here in this. Here, and here's the website for the Scottish Learning Disabilities Observatory, and please follow us on Twitter, and here's my Twitter site as well. So so thanks very much for listening, and be open to listening to any questions that you have.
Thanks very much, Lisa. That's really helpful. Okay. So if anyone does have any questions, then please do type in.
Sorry about the echo. Yes, thanks for everyone for listening, and apologies for the echo.
Would you like us
there was an echo in the start,
via voice or via the writing, Lisa? How would you like to take questions?
I think both, whichever you're comfortable with. I think. I don't mind.
There's
it's really
wonderful to
like
progress the work in the way that you're doing. When we're thinking about the causes of death, and particularly potentially avoidable causes and things like cancer rates, it strikes me that a lot of the work isn't standardised for the sort of the population. So that, for example, if we compared causes of death related to cancer in everyone with intellectual disability compared to the general population, because the population profiles are so different, we come up with different figures. So are people moving towards that sort of, making more of the data in terms of mapping it onto standard population so we can compare apples and apples, or not at this stage?
Yeah, I think there needs to be like a lot more work done to try and see how the data could be standardised. So to try and compare it using age and gender matched samples. So I see that there will be process. I know at the Scottish Learning Disabilities Observatory, they're doing some research at the moment in relation to looking at deaths of children with Down syndrome, and they're trying to compare that with the general population. So
yeah, so I guess if we adjusted stratified the populations and made sure we were comparing like with like, I think that would be helpful. And I know Tony's made that comment in the past. And the other thing that strikes me is that the adult population is very different to the child population, with the sort of dominance of deaths that relate to often the etiology of the disability and its impacts on physical health. So my sense is that there's also value in the future in splitting the populations and looking at children and younger persons as opposed to adults. But I guess there are lots of ways of slicing a cake, aren't there?
Yeah, that would be quite good. Yeah, to compare it on the basis of ages. Yeah, I think that would be a good way forward, because it's difficult to draw conclusions when you're comparing different ages. Oh, that's interesting. In a paper on death. No, we found. Oh, okay. Thanks. Just reading the comments as well.
Share the link
to
where the paper is published.
Yeah. So it's published in Jared. So so would you like me to open that link now? Or?
They can write down if they want to.
So can everyone see that now?
You can also click right on the slide in the webinar. So the link where it says the blue text that says link to early death paper, if you just click on that link, it'll open it in your web browser, but we can certainly circulate the proper reference.
Brilliant, thank you.
Yeah,
yeah,
question. Thank you, thanks for that.
The age of death over time in the comments.
Yeah, because Oh yes, we have just got a paper out on death in. Oh yeah, did any of the studies look at age of death over time? In terms of looking at age of death over time, we didn't really find any studies that looked. There was some studies that looked at death and age of death in terms of by children and older adults, but in terms of looking at, there wasn't that many studies that looked at age of death over time. So
study isn't she looking at that at the moment? I don't think she's published yet, but I think that's something that they are looking at in the Irish study.
Okay. So which is the reference for that
study
again, Pauline?
So it's Mary McCarran. If you.
Oh. Okay. Oh yeah, I have McCarran referenced in there. Yeah, in terms of looking at, yeah, so there should be a lot more papers coming out, hopefully, using some recommendations from these findings, which would be good. So it'd be interesting to see that paper on death in older people as well, and that how women have been older compared to men. That would be a really interesting
Eva, are you able
study to look at.
Can we share that paper of yours? Okay, there's no copyright issues with that, are there?
That would be great to see that paper, yeah. The Tilda study was a reference group of older people, 40 years plus. Yes, some of these studies would have looked at some by different age brackets, but it was difficult for us to synthesize in terms of comparing across all of the studies, in terms of because of the different ways of looking at age of death and life expectancy, to synthesize it on this basis. So that was a challenge in that respect. Yeah, the Yang study. Yeah, we've referenced. Thanks for that comment, Giles. We have referenced that in a new systematic review, which we've just completed, which is under review, and we've the Yang study in that, which looks at age of death in people with Down syndrome. So we've got a systematic review on individuals with Down syndrome. Yes, that would be great to hear about that study, Jenny. So we excluded some populations from institutionalized settings. So the systematic review wouldn't reflect individuals living in institutionalized settings. So yeah, thanks everyone for their input. That's great. Oh, Helena, the time period we included studies. They included. We didn't. It went right back to 1970, so it was quite a long time frame, the studies that we included.
Okay, great. Thanks very much, Lisa. So if there are any more questions, then people can just keep typing them, or we can come back to them later maybe. So thanks again. So now people to
and if
we've got a chance now for people to update each other about the work that we're currently doing. Jenny, do you want to start with yours, given we've just been talking about your work, and then we can just go round each person.
Oh, thank you.
And an update. So over to you for a few minutes.
Thank you. I don't know whether the slides will pop up automatically that I sent through, but we've just published in Journal of Pediatrics on whole population, thank you, looking at survival to 25 years, children born since 1983. So we looked at overall survival and by some different variables, which mainly by age groups, and then looking at level of intellectual disability. So our findings mirrored a lot of the systematic review main findings. We did also find a gender difference and females with higher mortality. So it will be interesting for us to perhaps look a little bit more closely at that. And we looked in very broad causes of intellectual disability. We were able to group those with autism as a group, and then we grouped the biomedical causes of intellectual disability. And then we, so if we just go back a slide, I'll just run you through briefly the age group differences. So, yeah, a six-fold increased risk of overall mortality, and that risk is obviously much higher in those with severe ID on that line. What was a little bit interesting is perhaps that for the age group of 6 to 10-year-olds, it was the highest risk ratios there, but I think it's possibly that obviously the younger 1 to 5, we did exclude deaths under 1 year of age because of those very genetic based high risk of death syndromes, and so we looked at survival after 1 year, and possibly that higher risk in the 6 to 10-year-old reflects maybe the reduced risk in the rest of the population of those years. I mean, there is a high risk for all population children 1 to 5 years, and then maybe there's the increased risk in the adolescents in the general population. So we see the ratio for our children reduces again a little bit in all children to 4.9. And perhaps that increased risk for the 6 to 10-year-old group reflects the fact that for children with intellectual disability, their risk of mortality is maintained, but for the rest of the population, they're in a not such a risky period of life when they're not risky adolescents and they're not in the risky of younger children age group. So obviously the biomedical group also are at high risk, and the autism is really only at risk in that middle 6 to 10-year-old. So if we want to just have a little look at the next slide, thank you, which is just the causes of death that we were able to look at. The cause of death was from information from our mortality database. And just a little bit of background, some of you may not know, is that our identification of children with intellectual disability in the whole population is through what we call the IDEA database, which ascertains children through disability services and through education, whole of population linkages. So we have we're confident of a very high ascertainment of children with intellectual disability, and we're able to link that with the whole population as far as looking at mortality statistics, and we can look at cause of death. So again, it was reflecting that very high risk with respiratory infection. We looked at aspiration separately. where we could, where it was identified as a cause, and that seemed to be a bit higher in the older group, 11 to 25 years. Not a lot of cancers, obviously, in the young children, but this is not comparing with the rest of the population, which we could look at. This is just the raw numbers of our children who died and a breakdown of those causes. Interestingly, accidents were also quite numerous in our children, and was represented, I think, 18% of the deaths in 11 to 25-year-olds, 19% in the 6 to 10-year-olds. So I'm not sure if there's anything specifically that you're interested in, but just interesting enough, we did find, of course, that that difference in females. So this paper is in Journal of Pediatrics. It was published in July and is available. I think it's pretty easy to find. The reference was on the first slide. But so in the analysis, we were able to adjust for factors such as gestational age and gender and year of birth, maternal age, parity. I'm just looking through, and we were able to adjust for socioeconomic status. So I guess, yeah, access to health is always an issue. And interestingly, we did look at race, and we didn't find the same increase in risk for Aboriginal children. So when we stratified by Aboriginality, we found that children with intellectual disability who were Aboriginal did not have an increased risk of death compared to other Aboriginal children, and sadly I think it reflects the high mortality in all children with Aboriginal children. So that was quite interesting to be able to show that too. Yeah, rather than congenital birth defects. Yeah, I think very true. The looking at the birth defects, deaths, yeah, congenital heart defects. Yeah, there were 24. I guess it's 24%, maybe survival for a number of years, but if that may represent, and we perhaps should look at this as trends over time, because probably a lot of those children are children with Down syndrome who in the more recent years would have had early surgery for their heart defects, and perhaps the high congenital heart defects represents the earlier born children with Down syndrome who were not able to access heart surgery in those early years. Yeah, and again for other birth defects, they may survive for those 1 to 5 years, but yeah, it's a good point. It would be really nice, Pauline, yes, if we could look at particular access. I guess we've got hospital data, so we can look at hospitalisations and whether that maybe increases when they transition to adult services which would perhaps reflect that they're not accessing primary health services as much. But yeah, we could look at that breakdown 11 to 18 and then 18 to 25, and we possibly could look at the gender differences more closely as well. So all good ideas, and I think it was just probably the numbers of deaths were lower in those older age groups. You know, a lot of the children obviously do die in under 5 years. So, yeah, break down the older group is something we could do. Oops, my computer's just... No, we're right. So unless there are any other particular questions, the cause of ID, I mean, it was interesting to see the accidents, and there was some information on accidents, and some were traffic and some were drownings, quite a number of drownings. Sadly, maybe in the older age group it does represent the normality of life for the more able in participating in life and being a little more vulnerable to the risks, accidental risk. And whether there's anything else of particular note, epilepsy, obviously numbers are quite high, and also quite high in the older 11 to 25-year-olds. But I think maybe we should look at it again as a trend over time because of the offer of early heart surgery for a lot of those children with Down syndrome, and it may show a difference of cause of death if we looked at the maybe 2 time periods up to the early 90s when surgery was probably offered more readily. But, yeah, respiratory infections, represent obviously the highest causes, so mirroring a lot of the systematic review. So very happy if anyone has any more comments or if you'd like to move to another topic.
Thank you, Jenny. So there is a chance for any of the rest of you all on the line to update you, to update us all on any of your current work. So, Emily, are you able to mute and unmute people to enable people to talk?
I think everyone should have access to speak. They can actually unmute themselves. So we haven't actually muted anyone ourselves. So if you're on the phone, you should be able to speak, and if you're on your computer, just go ahead and unmute your microphone if you'd like to speak.
Anyone interested in doing that?
But you could also type it if you're feeling a little mic shy.
Okay.
So I've just unmuted.
Tony or Julian, have you got anything else to add from Australia?
We're still working away with our sort of a slightly newer and extended data set. Only extends up to 2016, but I think the issues that seem to be coming out that we need to look at, particularly predictors of death, and also we've been doing some analyses around a cohort that we've been able to establish with younger people with autism. And looking at deaths there. That's not a new story. I guess it's just an Australian version of an existing story. And just trying to think also about this issue of potentially avoidable deaths. I think we need to be moving to analyses around potentially that the sort of predictors of potentially avoidable deaths. Because that's something, we think we can do something about those deaths. So I guess if we're going to give good advice and translate our findings into actions, we need to probably have more nuanced analyses around knowing how to prevent. I mean, here we jump up and down and make a big fuss about the very high rates of potentially avoidable deaths, but actually we need probably a more refined story to be able to tell, targeting particular types of death. And then the only thing else that strikes me is just this need to, when we're looking at particular groups, particular causes of death, we need to have a better story around, comparison with an appropriately stratified sample. And I know Tony's been thinking a little bit about that. I didn't know if you wanted to say anything. I just know he's mentioned that before.
Right, thank you. Helene, you've mentioned that you've got papers out. Could you let us know where they are so that we can have a look at them?
Okay, they're not published. They're in the works. We're working on them as we speak, and so we're hoping that we'll have them submitted within the next month or so. But we're looking at patterns of mortality in terms of age and sex in comparison to the general population, and also over time. But we only have 4 years of data to look at. To look at that, and we're restricting to individuals 25 years and older. So that's the specifics of what the papers we're working on. We're finding very similar things to what's been reported so far. And we hope to also prepare a paper on avoidable mortality. We have it drafted, but one of our major problems is that we have found that IDD continues to be commonly coded as a cause of death, especially among those with Down syndrome. So we are very limited as to reporting on causes of death. That's in Ontario, Canada.
I'm not sure it is an Ontario thing. We had a meeting with our Office for National Statistics and asked them why Down syndrome was often coded as a cause of death. And they explains about, that it's their new electronic coding system means that it's automatically coded as a cause of death where somebody dies with dementia who also has Down syndrome. So their automatic electronic coding now just routinely allocates the underlying cause of death as being Down syndrome. So I'm not sure it is just an Ontario problem.
Certainly a US problem as well.
Yeah, and when we looked at our cause of death information as well, Helene, it was, in some of them, it wasn't a lot, but when it was Down syndrome, we had linkages to the birth defects. So I think for some of them, they had a heart defect, and I think, maybe we had assumed that could have been related to death, which is perhaps, why sometimes Down syndrome is used as their cause, but hopefully that's not, it's certainly becoming more specific causes of death, and I don't think they're using Down syndrome as a cause as much in our more recent mortality data.
Yeah, we think it's quite possible that
it's really interesting, isn't it, as to whether we should or shouldn't. And I remember we've had discussions about that before, haven't we, in terms of are we comparing like by like if some do and some don't. Have you got any more thoughts about that?
I was since we're a group of people interested in mortality, it's Rob speaking from Canada. Since we're a group of people interested in mortality in this population, it might be useful because I think we're all in agreement that we shouldn't be putting things like Down syndrome as a cause of death, to put out some kind of statement that gets out to readers beyond the IDD world that says this is inappropriate, we shouldn't be doing this anymore, and get the message out broader. And I'm not sure how to do that, but there's got to be somehow a way to get that to a broader group of readers. Are we all in agreement that that sort of thing shouldn't be listed as a crime?
It's really, really important so that we are all recoding the same way.
I think also noting that in the methodology would be important, both that you've done it, but also how you're doing it. I mean, I think from my perspective, there is a reason to recode, because I think that the error in the coding, and I'm using error loosely here, but it is more specific for people with IDD due to what we, at least in the U.S., called diagnostic overshadowing. All they can see is the disability, so that it's an error more specific to people with IDD versus a need to recode, the general population for some other reasons. But I agree that we need to be really clear about when we're doing it, how we're doing it, especially in the middle of where we may not have a standardized or agreed upon consensus on how to do it at these early stages.
Okay. Work. Shall we move on? Happy? Okay. Shall we just spend the last 10 minutes then feeding back the notes from the IACID Healthberg meeting? We had a subgroup meeting of those interested in mortality, and we've just got a couple of slides to kind of talk through with you, really, in terms of what was discussed and agreed. So, as I mentioned, the meeting was in June, and I hope this is the right attendance list. So, Emily, myself, Giles, you were there, Julian, Priyaporn, Benny, Helen, Shine, Rob and Eva. And what we discussed was task and finish group actions that we plan to present at the IACID European Conference in Athens in July 2018. And there were two key actions that we proposed from our group. One was to issue a call for action about the importance of the work. And secondly, it was to revisit and finalise guidance for reporting comparable data about mortality of people with IDD. So if you look at the first key action first, which was the call for action about the importance of the work, we just discussed a couple of things, really. The first being that we would draft and agree an international that's coming really from a human rights framework perspective that presents an overview of the evidence about the extent of inequalities in mortality, and hopefully includes information from low and middle income countries if possible, and that results in a call for action that's based on sort of good, better and best aims or targets. We're not allowed to use targets in the UK anymore, so it's aims, I think. And then once that consensus statement has been circulated and agreed, we'd seek to obtain an endorsement from IACID about it, and then circulate it to our own governments to to kind of challenge, what are you doing to support the work. So that was the first kind of task that we agreed we would try and complete by July next year. Shall we pause there, and does anyone have any questions about that action other than who's going to do it, which we'll have to come on to in just a minute?
I'd be interested to see how information would be collected from low and middle income countries. So what kind of thoughts do you have about how that kind of information would be collated? Or
so we were going to look for volunteers to support that. Yeah.
Okay, great.
Shall we move on to the other issue as well, and then people know what the whole map of the work is, and then we can look at what we want to do. So the second task that we agreed would probably be feasible for us to do by next July is to revisit and finalise the guidelines for reporting comparable mortality about people with IDD. Do you remember a couple of years ago we drafted some guidelines, and it was probably some of the earliest work that we did together. So we thought that we could revisit those, conduct a Delphi exercise to agree a list of causes of death that are considered amenable to good quality care, and ask an international group of medics to review the codes used for IDD and issue recommendations for researchers, and then include both the findings from the Delphi exercise and the findings from the medics in the finalised guidelines, and circulate those. So hopefully we're, as much as possible, trying to conduct research in a way that's comparable internationally, so we do have better internationally comparable data about mortality. So those were the two tasks that we kind of thought were probably feasible to do. And anyone else who was at that meeting, do you want to add anything else to that overview?
Pauline, it's Julian. I just wondered with the second point on this current slide, I'm just rethinking that. Do we really want to differentiate this group from the general population? I mean, there is an already existing agreed list on causes of death which are considered potentially avoidable. Should we be refocusing attention back on that agreed international kind of list, or should we be reissuing one that's tailored to people with intellectual disabilities specifically? I worry about the second angle, just because from a public health point of view, we've got a strong argument when we aim for kind of, we want to see the gap closed in potentially avoidable deaths for the general population.
Julian, I'd like to weigh in on that. This is Emily from the U.S. We've looked at some of those guidelines that are developed in the U.S. and in other countries, and I think I have two concerns about them. One is that they often don't include people with intellectual disabilities as a considered group, and so the guidelines often don't speak to some of the very specific needs in this population. But the wheels that might be preventable or amenable, it's sort of like we would take those guidelines and potentially add on to them. They just don't quite speak exactly to this population. So I hear your concerns, but I'm also just concerned about the fit to this group. But I'd be curious what others think.
So for the list, if you were to look at the if you were to look at the list of potentially avoidable causes, I guess it's a matter of recognising that some are much more a feature in people with intellectual and developmental disabilities. Is that the kind of angle that you were coming at, or do we need a distinct list for the group?
The starting point should be the list that exists for the general population, and then for us to think about how that might look differently to people with intellectual disabilities. Would that be a good starting point? So that we're not starting with a blank sheet of paper, but that we're thinking quite critically about its relevance to people with intellectual disabilities as we're going through it.
I think it's a really interesting exercise to do, and to see if we come up with a distinctly different approach, or whether it's just a matter of making sure that the common causes of potentially avoidable deaths are recognised and that more assertive action is taken for the group. So I think doing the exercise will help clarify that, won't it?
Yeah, I think so. Presumably we have different lists in different countries too. So I guess there is going to be some degree of boxing and coxing here as well, because I would guess that we don't have a very neat fit between different countries. I don't know, I haven't looked at other countries' lists, but
that crosswalk may be the very first piece we need to do, is to kind of get an exhaustive list and look at similarities and differences, and then review it for application to this population. And I think then is bringing up another important aspect of the potential conflating of congenital anomalies, or kind of the overshadowing of Down syndrome and things, and those may be cautions we have to kind of attach on to these recommendations. So it seems like there's a few different considerations we need to take maybe in the stepwise process.
Yeah. Certainly the list in the UK has been revised, and a number of causes of death related to congenital anomalies have been removed from a list of amenable deaths now, which has been interesting.
And I noticed Chris had a comment earlier about whether this guidance that we're talking about on this slide could include guidelines on the death certificate reporting. And I think that this is something we talked about in that task and finish group discussion, where perhaps we would have guidance on those causes of death which should never be used, and that might be something that had an audience for the World Health Organization or others that kind of dictate this coding. And I don't know if Pauline, you want to say a bit more about that.
Yeah, we've just submitted a paper about was the death coding actually to Jared. I think it went to in the end, so we're waiting to hear about that. But we can certainly share that with you all in its submitted form. It won't be subject to copyright yet. So if that's helpful, we could send that round to you. It's a really important point to go. It's of international relevance, not just specific country relevance. Okay, so that's really helpful, thank you. There's lots of people typing in, so just want to make sure we're not missing any points. So including recommending, disappeared. IDD code, Helene has suggested, I think would be really helpful. And Jenny talking about, don't want to miss the point about risks, differentiating risks for people with mild and more severe LD. And Giles making the point about looking at how deaths due to congenital causes are handled. Okay. So, Emily, we can capture all of these chat comments, can't we?
Yes, absolutely.
And send them round?
Yes.
Okay, that'd be great. Thank you. So I just want to make sure we don't lose them when we're coming to work on the work that we're going to do.
Yes, and we have recorded this webinar too, so that if there's a piece anyone missed or somebody wasn't able to attend, we'll, as we always do, we'll post that link, but we'll extract the chat so we have that.
Okay, thank you. So I'm aware of time. The final slide that I was going to go through really is just kind of what next, really. So we've talked about, I already mentioned the 3-year funding from the ESRC is now at an end, and we've transferred some outstanding money to Emily's team to support the ongoing webinars. But how frequently do people want those? We've always had them quarterly, so we've had 4 a year. Does that feel about right for people, or would you like them more frequently or less frequently? So any views would be very welcome about that. So just type your comments and we'll pick those up as we go. We also need to set up a web page. We do have a web page which is hosted by the University of Bristol, but rather bizarrely, as soon as your funding stops at the University of Bristol, your web page disappears, which is pretty ridiculous. So we would need to transfer the web page over to somebody else. Now, Emily, you've offered to host that, which is really kind. Thank you. But I just want to check if anyone else wants to do so, or if we're all going to jump into Emily's kind offer and accept that. So again, if you could type your comments on that, that would be really helpful. The third point is that we need to, rather than like to, engage with people in low and middle income countries as well. And I know that at the June discussion we had, there was mention of an IACID group that looked at low and middle income countries, and I couldn't remember what the contact detail was or how we get access to that group. So I don't know, Helene, if you can help us with that. It would be really helpful if you could. Thank you. And then the final 2 points are in relation to the IACID Europe conference in Athens in July. Asking if anyone wants to help run a masterclass about mortality, and then if people want to group papers together again for a symposium at the conference, it would be good to know that fairly soon as well. So type away with the answers to your questions. That would be really helpful, thank you. Or chip in on the phone if that's easier. And then I guess going back to the work we've planned, it would be really helpful to know who's interested in doing what. You can either commit yourself in public on the webinar, or you could email the group or Emily and myself and let us know what you'd be interested in helping with. That would be really helpful. Otherwise, we might come looking for you to ask you to volunteer. So. Emily, do you want to have you got anything to add from to pick up from the discussion we had in June?
I think the only thing would be that in addition to the two things we talked about, there was some discussion about what it would take in terms of resources to do to kind of advance our findings and whether we want to do some collective grant applications, that sort of thing. I think those may be a little bit further in terms of not so much of our low-hanging fruit, but important nonetheless. And so I think as part of these discussions, it would be really helpful to keep thinking about these. And I think that the notes were circulated, but we should just kind of keep those fresh and keep our eyes out for opportunities that we might see in any of our countries or in a more worldwide fashion.
Okay. So people are thinking sort of 3 to 4 times a year for webinars is okay, but we might also consider the work plan, and I guess maybe have them a bit more frequently if we've got particular work to do together. So I think that's a really good point. So I guess that depends on engagement with the work plan. That's okay. And thanks for the IASIS contact, Helen, that's really helpful. And Julian, for your offer of contacting Thailand researchers, that would be great as well. Thank you. We've got a researcher working with us at university doing a PhD who's from South Korea, actually, and she was in contact today with me, asking me about how she could get involved with the group. So she wasn't able to join the webinar this evening, but I'll cultivate that link and see if she knows what's going on in South Korea. Okay. We probably ought to call it a day, but we will be in touch with sharing the notes of the presentations on the webinar and the notes that are associated with the chat. And then also with the future work plan and inviting contributions, and if you could make sure that you let us know if you'd like to be involved in any way, particularly with the IASIS Europe conference as well, with papers or a masterclass, that would be really helpful too. And otherwise, thank you very much to Lisa for presenting your work, and to Jenny as well, and to everyone who's contributed. And thank you very much to Emily and Courtney for hosting the webinar as well. So good to speak to you all, and thanks very much. Until next time.
Yes, thanks very much everyone for attending and listening to the presentation. So thanks for organising, Pauline.